Peripheral arterial disease. There are different ways to support peripheral arterial disease in the provider's documentation. It will depend on whether the patient is symptomatic or asymptomatic. Documenting the clinical manifestations or clinical indicators is a fundamental element to support this condition when the patient is symptomatic. Use existing signs and symptoms in different parts of the SOAP notes. For examples: intermittent claudication noted in the review of system. Abnormal or weak pedal pulses, abnormal leg skin color, cool skin temperature, or presence of femoral artery bruit documented in physical examination. If the patient has no symptoms, document the result from arterial Doppler and/or ABI and its clinical significance to report arterial disorder such as atherosclerosis, calcification, stenosis, or occlusion of artery of the lower extremity. Document in the notes the result and also the date when the test was performed. Besides the clinical findings and the type of vascular disorder, healthcare providers must also be specific about how they will manage this condition. These details will be documented in the plan. For examples: start aspirin 81 mg once a day. Avoid long periods on sitting or standing position. Avoid any tobacco products and secondhand smoking. Diabetic peripheral neuropathy. There are different ways to support diabetic peripheral neuropathy. It depends on whether the patient is symptomatic or asymptomatic. When the patient is symptomatic, the healthcare provider needs to document symptoms, manifestations of neuropathy. For example, pain, tingling, numbness, prickling, or burning of both legs as described by the patient. Or loss of protectress sensation assessed by monofilament testing. If there is no symptom to document, report the diabetic peripheral neuropathy as stable or improved on medication such as gabapentin, Cymbalta. Or diabetic peripheral neuropathy being managed by the neurologist. Diabetic autonomic neuropathy. Autonomic neuropathy happens when the nerves that control involuntary bodily functions are damaged. It can affect blood pressure, temperature control, digestion, bladder function, and also sexual function. Therefore, diabetic autonomic neuropathy could be supported by documenting signs and symptoms depending on the damaged involuntary bodily function. They might include delayed gastric emptying symptoms such as feeling full after a few bites of food, loss of appetite, constipation, abdominal bloating, nausea, vomiting. Diabetes diarrhea, one of the lesser-known complications of diabetes. Altered bladder function, such as decreased sensation of bladder fullness, urge or overflow incontinence, difficulty starting urination, or inability to empty the bladder completely. Impotence as problems achieving or maintaining an erection or ejaculation problems in men. Vaginal dryness, low libido, and difficulty reaching orgasm in women. Orthostatic hypotension causing dizziness and fainting when standing. Decreased heart rate variability leading to exercise intolerance. If there is no symptom to document, report the diabetic autonomic neuropathy as stable or improved on medication, or diabetic autonomic neuropathy being managed by the neurologist. Atherosclerosis of aorta. Even though having atherosclerosis of the aorta makes the patient more likely to have serious problems such as stroke, aortic aneurysm, aortic dissection, or limb ischemia, this condition has no symptoms at first. The only way to support it is by documenting the imaging test that shows the specific part of the aorta having the atherosclerosis process such as echocardiogram, X-ray, CT, MRI of the chest or abdomen, the date when the test was performed, and how this condition will be managed. These details should be documented in the plan. For examples: stop smoking, eat heart-healthy foods such as fruits, vegetables, whole grains, fish, lean meats, and low-fat or non-fat dairy foods. Exercise at least 30 minutes most days of the week, such as walking. lose extra pounds and maintain a healthy weight. And reduce stress as much as possible. Type 2 diabetes with hyperglycemia. Diabetes with hyperglycemia will always be reported instead of uncontrolled diabetes, which has two different meanings. Hyperglycemia should be noted in the medical record when it exists, as it is a complication of diabetes. Documented uncontrolled diabetes is insufficient information for coding, as it could indicate hyper or hypoglycemia, and defaults diabetes without complication. To support diabetes with hyperglycemia, the healthcare provider must document the high blood glucose level measured during the encounter and its clinical significance, hyperglycemia. For example, you should document the patient's blood glucose indicates hyperglycemia at 400 rather than documenting blood glucose equal to 400. Acute myocardial infarction. Sometimes, not being specific about the timelines and dates can affect diagnosis code assignments. This is the situation with myocardial infarction. Myocardial infarction is usually an emergent condition treated as an inpatient encounter, with follow-up and ongoing care often provided in the physician's office. Always note the date of the myocardial infarction in the notes because ICD-10-CM differentiates between a myocardial infarction in its acute phase, meaning within 4 weeks of occurrence, and encounters for that same myocardial infarction occurring at a later time. Therefore, to support acute myocardial infarction, the physician should clearly document specific timelines or dates associated with the myocardial infarction to indicate whether this condition occurred 4 weeks ago or less. For encounters happening within the first 4 weeks, the myocardial infarction is reported as acute as long as the patient is still receiving care and treatment related to this condition. After the 4-week time frame, document encounter for aftercare if the patient is still receiving care, or old myocardial infarction if the patient does not require further care. Here is an example of documentation with no support for acute myocardial infarction. This morning, the patient is seen for a follow-up visit on acute myocardial infarction, for which he was admitted to the hospital recently. Here are 2 examples of documentation supporting acute myocardial infarction. This morning, the patient is seen for a follow-up visit on acute myocardial infarction, for which he was admitted to the hospital 2 weeks ago. Hospital follow-up after discharged from Memorial Hospital on June 30, 2021, after inpatient admission on June 26, 2021. Acute cerebrovascular accident or stroke. A stroke is an urgent condition requiring emergency care. In all cases where a stroke patient is seen in the physician's office, the patient is seen for follow-up care or sequelae, not for the acute stroke. Stroke is considered an inpatient diagnosis for coding purposes since acute cerebrovascular events are managed in a hospital setting. Coding for acute CVA in the outpatient setting is inappropriate. But in a physician's office, it is okay for the healthcare provider to report any residual deficit or late effect of the stroke, such as monoplegia of the lower limb, monoplegia of the upper limb, hemiplegia, hemiparesis. The site and the type of stroke should be documented at every encounter in which sequelae are addressed. Identify if the initial event was hemorrhagic or ischemic. Emphasize all extremities that are weak from the stroke. For patients experiencing hemiplegia or hemiparesis from the stroke, document which side is dominant and affected. If no residual deficits are present, document history of CVA or history of stroke. Angina pectoris. Angina pectoris is a common symptom of ischemic heart disease. When documenting this condition, identify it as stable or unstable. Link it to its underlying cause, such as coronary atherosclerosis or coronary spasm. If patient angina is controlled with medication but would recur if taken off their medication, the angina is stable. If symptoms break through their current treatment, angina may be unstable. There are different ways to support angina pectoris. It depends on whether the patient is symptomatic or asymptomatic. When the patient is symptomatic, the healthcare provider needs to document the clinical manifestations. For example, chest pain, pain spreading to shoulder, arm, neck, throat, jaw, or back, shortness of breath, sweating, or dizziness, feeling of pressure and crushing. If the patient is asymptomatic, document angina pectoris stable or controlled on medication such as nitroglycerin, or angina pectoris being managed by the cardiologist. Cancer. How ICD-10-CM classifies malignancy is different from how a physician perceives cancer and its treatment, and this can be a significant source of error in risk adjustment audits. Healthcare providers should use terminology that allows coders to abstract the appropriate diagnostic cancer for the patient. In ICD-10-CM, the only malignant conditions that can be classified as in remission or in relapse are multiple myeloma and various leukemias. Other cancers are identified as history of disease, meaning the condition has been excised or eradicated and all treatment completed, or active or current disease. Generally, cancer is reported as current when the medical record clearly shows active treatment directed to the cancer for the purpose of cure or palliation and/or when the record clearly shows the cancer is present, but is unresponsive to treatment. The current plan is watchful waiting or observation only, or the patient refuses any further treatment. The provider must clearly indicate whether cancer is current, not historical. Document whether current cancer is primary, secondary, or in situ. Document laterality for paired organs, right or left. Clearly state the goal of the treatment, such as chemotherapy, radiation therapy, surgery, or stem cell transplant. Clearly state the purpose of the treatment such as curative, palliative, prophylactic or preventive. Linked complications caused by cancer. For example, diabetes secondary to pancreatic cancer, pathologic fracture due to breast cancer, anemia due to cancer, anemia secondary to cancer treatment. Metastatic and metastasis can be ambiguous in describing the primary and secondary cancer sites. Use of the words to and from in notes will clarify the origin of the neoplasm, or simply use the descriptors secondary and primary. Primary hypercoagulable state. Hypercoagulable states are usually primary or secondary conditions. The primary, genetic, or inherited form of this disorder means a person is born with the tendency to form blood clots. Secondary or acquired conditions are usually a result of surgery, trauma, medications, or a medical condition that increases the risk of hypercoagulable states. Primary hypercoagulable states increase DVT risk. The most common inherited abnormality is factor V Leiden mutation, which affects 3% to 8% of the population. Other primary hypercoagulable states are caused by prothrombin mutations and deficiencies of protein C, protein S, and antithrombin. Primary hypercoagulable state has been reported so often without documentation of indicating factors and/or lab tests to support the hypercoagulable state as primary. Some factors may indicate a primary hypercoagulable state, and they should be documented to support this condition. A family history of thrombosis. History of frequent miscarriages. Recurrent thrombosis without apparent precipitating factors. Thrombosis at unusual anatomic sites such as arm, liver, intestine, kidney, brain. Thrombosis at an early age, less than age 50. And resistance to conventional antithrombotic therapy. Patients with these factors may be candidates for screening for hypercoagulable states. Tests used to help diagnose primary hypercoagulable states include genetic tests, including factor V Leiden and prothrombin gene mutation, antithrombin activity, protein C activity, protein S activity, fasting plasma homocysteine levels. Secondary hypercoagulable state. Secondary hypercoagulable state is often underdocumented and underreported by healthcare providers, missing the opportunity to increase reimbursement. As we said previously, hypercoagulable states can also be secondary to a condition or event such as previous thrombotic events, cancer, use of some cancer medications or oral contraceptives, recent trauma or surgery, pregnancy, hormone replacement therapy, prolonged bed rest or immobility, heparin-induced thrombocytopenia, prolonged sitting or extended travel, myeloproliferative disorders such as polycythemia vera or essential thrombocytosis, central venous catheter placement, renal disease such as nephrotic syndrome, end-stage renal disease, liver disease, persistent atrial fibrillation, systolic heart failure. Secondary hypercoagulable states include antiphospholipid syndrome, an autoimmune syndrome characterized by autoantibodies against plasma membrane phospholipids and phospholipid-binding proteins. That is why tests used to help diagnose secondary hypercoagulable states include lupus anticoagulant, anticardiolipin antibody, anti-B2 glycoprotein 1 antibody. Documentation of secondary hypercoagulable state must meet the definition of secondary diagnosis. That means it must include presence of conditions or events that trigger the hypercoagulable state or risk factor, abnormal coagulation profile, diagnostic tests, treatment. Substance use disorder. Substance use disorders occur when the recurrent use of alcohol or drugs causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. The most severe substance use disorders are sometimes called addictions. Substance use disorder in DSM-5 combines the DSM-4 categories of substance abuse and substance dependence into a single disorder measured on a continuum from mild to severe. Other than caffeine, which cannot be diagnosed as a substance use disorder, each specific substance is addressed as a separate use disorder such as alcohol use disorder, stimulant use disorder, etc., but nearly all substances are diagnosed based on the same overarching criteria. Substance use disorders are classified as mild, moderate, or severe, depending on how many diagnostic criteria a person meets. The 11 DSM-5 criteria for a substance use disorder are: hazardous use. You have used the substance in risky situation such as driving a car or operating machinery. Social or interpersonal problems related to use. Substance use has caused relationship problems or conflicts with others. Neglected major roles to use. You have failed to meet your responsibilities at work, school, or home because of substance use. Withdrawal. When you stop using the substance, you experience withdrawal symptoms. Tolerance. You have built up a tolerance to the substance so that you have to use more to get the same effect. Used larger amounts, longer. You have started using more significant amounts or using the substance for more extended amounts of time. Repeated attempts to control use or quit. You've tried to cut back or quit entirely but haven't been successful. Much time spent using. You spend a lot of your time using the substance. Physical or psychological problems related to use. Your substance use has led to physical health problems, such as liver damage or lung cancer, or psychological issues, such as depression or anxiety. Activities given up to use. You have skipped activities or stopped doing activities you once enjoyed in order to use the substance. Craving. You have experienced cravings for the substance. To support mild substance use disorder, healthcare providers must document in the notes the presence, over the past 12 months, of 2 to 3 criteria. To support moderate substance use disorder, healthcare providers must document in the notes the presence, over the past 12 months, of 4 to 5 criteria. To support severe substance use disorder, healthcare providers must document in the notes the presence, over the past 12 months, of 6 or more criteria. Suppose no criteria can be no longer documented for at least 3 months or more to support the specific substance use disorder. In that case, the physician should report specific substance dependence in remission instead of history of substance use disorder. Seizure versus epilepsy. Even though the term seizure and epilepsy are sometimes used interchangeably, they are not the same. ICD-10-CM classifies seizure as a sign or symptom. Seizure is seen as an isolated, one-time, sudden, transient event, and it is coded as convulsion. Epilepsy, also named seizure disorder, is a brain disease characterized by recurrent unpredictable seizures. In the absence of a diagnosis of epilepsy, document the causes of the isolated seizure, such as fever, trauma, hysteria, stroke, meningitis, drug withdrawal. Document also the tests ordered or test results interpreted, for example, hyponatremia, hypomagnesemia, hypocalcemia, hypoglycemia, drug overdose. If known, document the treatment of the underlying cause. Do not report history of epilepsy for a patient whose condition is controlled with medication. Document if epilepsy is focal or generalized. Document if properly dosed antiepileptic medications do not control the seizures to know if epilepsy is intractable. Document how long the patient stays unconscious between seizures to document any status epilepticus. Document any external causes. And document the medication.